Hello and welcome to Level 3 Health and Social Care Unit 6 Stroke. We're now on part 5 it's part 5 in week 3, looking at diagnostic investigations related to stroke. Okay, and the objectives of this part of this week is looking at the criteria 2.2, and we're going to compare and contrast the available investigations associated with the diagnosis of CVA. So we're going to look at the types of investigations that are used to diagnose CVA or a stroke. Okay, and for your assignment, you need to compare and contrast. That means you need to take at least two of them and compare them to each other and sort of show what the differences are. We'll look at that a little bit towards the end of the slides. Okay. So the first thing that you do when someone comes into hospital with a suspected stroke, the doctor will want to find out as much as they can about your symptoms. So they take a history. They do the fast checks, if you remember, FAST, which we looked at in one of our recent sets of slides. And they will do those sort of same checks. So they look at people's faces, they'll look at their arms, the sort of movement. They'll look at if there's any drooping or paralysis on one side. So some of the things we've already talked about, really. There are also a few other tests that will be done to confirm the diagnosis and maybe to find out a bit more about the cause. So we're going to look at those. They will take a blood test to find out cholesterol, blood sugar level, and they will check pulse and blood pressure to find out if looking at people's heart rate and looking for irregular heartbeat. As we know, atrial fibrillation is one of the sort of factors for stroke. So they'll probably take a stethoscope and have a listen as well to see how the heartbeat is regulated. And if they're concerns about that, they'll do it electronically as well. So the next thing that they'll sort of get to fairly quickly, hopefully, is having a brain scan of one sort or another. So even if the symptoms are obvious, nowadays the new guidance is that brain scans must be done. First of all, you need to find out what's happened. If it's a blocked artery, blocked by a blood clot, like an ischemic stroke, or a burst blood vessel, a hemorrhagic stroke, because obviously there's going to be different interventions to those two. One of them, the brain is filling up with blood, and the other one, the artery is blocked, so blood isn't getting around the brain. Both of them are quite serious. Both of them cause strokes, but obviously you're going to intervene differently. The other important thing about a brain scan is it will look at which part of the brain has been affected. It can look at the level of severity of the stroke, which gives them some ideas about what they need to do. It's really important to do it for people who you might be able to give them medication very quickly to clear the blood clots and break them up, and that will obviously reduce people's risk of getting more seriously unwell. And it's really important if people are already taking anticoagulant medications, that could have caused the bleed if maybe they haven't been working that well. Or if someone's unconscious, you really need to see what's going on, so a brain scan's important. The present recommendation is that they have to have a brain scan within an hour of being admitted to A&E. It is an emergency, as I said. It should be done within an hour. If it isn't being done, then people need to sort of, find out why not, really. A stroke is a medical emergency. So if you have any concerns about somebody at all, be it a friend, relative, or a neighbour, or somebody you work with in a care home, then you need to call 999. You do not arrange for a GP's appointment. Okay. And if somebody in your care home is suggesting that, you need to sort of be fairly insistent and say, look, if these are symptoms of a stroke, we just call for an ambulance. 999 in the UK, 911 in the US, and whatever number it is in the country that you're in. So, looking at the different types of brain scans, one of them is generally known as a CT or a CAT scan. You may have heard of that in hospital dramas. It's computerized tomography, but generally known as CT scan. And it's sort of like an X-ray, if you can see from the images here, but it builds up multiple images. So it actually becomes a bit more three-dimensional than an X-ray, which is just a flat seeing through to the bones. And you can identify some problem areas in it by sort of comparing things. Sometimes they may inject a special dye into one of the veins in your brain, and that can help improve the clarity. So if it's all a bit cloudy and I can't see well, they might do it again. It usually shows up, it very clearly shows up the difference between ischemic and hemorrhagic strokes. And it's quite a quick process. So it's quicker than an MRI. And it usually means that they can do that from A&E straight into CT scan. Takes a few minutes, and then they can start, get people away and start looking at treatment. So it can be a quick process. Just to give you an idea, if you have a look at these two brain scans here, one shows an ischemic stroke and one shows a hemorrhagic stroke. Okay, now the hemorrhagic stroke we know is the one where the vessel swells up, pops and bleeds. So if you can see the white shading on a hemorrhagic stroke, that's where there's blood bleed has gone into the brain, and it's very clear, so you can see that hemorrhagic stroke quite well. The ischemic stroke is not so obvious. It's a much darker shaded area, as you can see. It's in the same area as a hemorrhagic stroke, but it's shaded, and that's where the blood isn't naturally flowing. So there's probably some sort of blockage just at the point there, where you can see the shading goes into a little bit of a point, and it's possible that the blockage can be there, and that means that the blood isn't naturally flowing. So the rest of the grey area is where the blood is sort of flowing and sort of wobbling its way around the brain. So that dark grey shading is where blood isn't around, and the very white shading is where there's a lot too much blood. Okay. So the other option is MRI. Most of you have heard about MRIs. They're a bit more modern than CT scans, and they're a little bit cleverer as well. You lie in a very large circular magnet, so you sort of slide into it. They are a slow process. They take lots and lots of pictures, and then it creates an image. It's the magnetic field and the radio waves produces actually a much more detailed picture than CT scan, and it can take pictures of any parts of the body, really, soft tissue and hard. And it's used in people who have got complex symptoms where they're not really sure of the damage. So they may well do a CT scan first, and if they feel they need to see a bigger picture, they may use an MRI. Now, there's a lot of research going into stroke at the moment, and we'll be talking about that later in other sessions. But there is a big discussion about whether maybe they should go straight into using MRIs. But it is a slower process, and often we only have sort of one MRI in a hospital. Sometimes it's not even in the hospital that the person's in. They may have to be taken to another hospital for an MRI because they're very expensive pieces of equipment. They often need to be fundraised for, and not all hospitals have them. So there is a bit of an issue there, but some stroke specialists are saying that really in that first hour, you should have an MRI because it's got all the detail, all of the picture, much wider picture. It's particularly useful for people who've been having TIAs because it can show evidence of where the TIAs have been. It may not look like a lot more detail to you, but I can assure you to people who are trained to read these, it is actually more detail. It's probably not the best picture I've got. You've got the same here. You've got hemorrhagic and an ischemic. So you can see the sort of dark shading and the white shading in the same way, but within MRI, it all tends to come up in all sorts of different shades of colour, so you can actually see the movement of the blood through the veins. So that'll be an initial shot, and then they'll do something much more focused as well. So it can show brain tissue in greater detail. So after this, so once they've seen where the stroke area is, they will zoom in on it, and you will actually see the area in very large detail. Okay, and that's really useful. As I said, again, they'll often put the dyes through, so all the veins will light up. So you might see the white area on B where the bleed has happened, but then they can really zoom into the area and see where the bleed has come from and that. So it's really quite that good. Okay. So that's MRI against CT, and we'll be looking at maybe thinking of comparing those two later on. Why else would we use scans? We use scans also to find out things called stroke mimics. So we use scans to find out what the cause isn't as well. So sometimes we might be sort of wondering, is this actually a stroke? And a scan can help us do that as well. So a scan can rule it out. You know, you can see the popped blood vessel, or you can see where the blood clot has been. And it rules out such things as psychiatric disorder. So sometimes people with mental health problems can have some of the effects of stroke, like paralysis and that, but they're not actually paralyzed, but it's part of what's going on in their head. And if they can take away the cause of a stroke, they can start looking at it differently. Some people have seizures and paralysis for other reasons, sometimes from an infectious disease that can actually cause that. That could be one of the side effects. There can be some sort of toxic, like some sort of poisoning, or a metabolic disturbance, so something that's affected the metabolism of the body, not working properly. Maybe a hormone imbalance, something like that, which they might pick that up a bit in bloods as well, but they would definitely check it out with the scan. It might be a brain tumor. They can have very, very similar symptoms, but obviously the cause is different because it's something that's actually growing in the brain. And only a good scan will really show that. A CT and the proper detail of an MRI would be needed to show the extent and the brain tumor, exactly where it's latched onto, what it's stuck onto, and things like that. Infections I've mentioned, it could be very, very severe migraines, and there's a whole area of medical science around migraines, complex things which I would say they've not completely explained. But some people have terrible reactions to migraines to the point that it could simulate some of the stroke symptoms. So to find out, to rule out some of these stroke mimics, you need MRI generally, or CT at the very least. So a scan of some sort, really. Why do we choose one or the other? I've mentioned a few things. We're going to address that a bit later on. Well, you're going to do that as a piece of work for yourself. Historically, CTs are cheaper, they're quicker, and most hospitals have them. They might have more than one CT space, so they usually have several. So, you know, there may be a bit of a queue, but people will get into them fairly quickly. MRI really visualizes things a lot better, but it's quite a slow process. You go in to do an MRI, it can take half an hour, depending on how many shots you're breaking it down into. And it takes time anyway. It's just a slower machine, really. In an emergency setting, there's quite a lot of pressure to deal with patients with any form of stroke, really. So that's why they tend to lean to CTs because they're usually very quick and available. However, as I mentioned earlier, in 2010, the American Academy of Neurology issued a guideline saying that MRI should always be the first choice because it will give you the details straight away. You don't have to come back and do it again to add to your diagnosis. And they've identified, they just did some studies in America that identified that stroke was accurately detected 83% of the time by an MRI and sometimes only 26% of the time by CT. So there could be something in the CT that obscures. The pictures I showed you earlier were sort of quite big and obvious, but sometimes a bleed might be very tiny and it's just a little dark blob and you might not see it so well. Whereas an MRI is much clearer. So some would say, well, because of the accurate diagnosis level, MRI should be numero no choice, really. You're going to discuss this a little bit more because it's one of the questions that you're asked as part of the assignment. And I've put some notes in extra reading for you to have a look at, comparing MRI and CT to help you sort of come to your decision. Swallow test. Why would we do a swallow test? Take a minute to think about it. So why would we want to test someone's swallowing ability? I'll give you a minute to think about that before I go on. So see if you can come up with some ideas yourself. Take a moment. Okay, let's see if you've come up with some ideas. Swallow test is really essential for anyone who's had a stroke. When someone can't swallow properly, there's a risk that you can get your food and drink going to the windpipe. So if you're just delivering them regular care, you could actually make them a lot iller, really, if they can't swallow properly. And as we know, there are certain types of strokes that can affect the swallowing and the throats and the area. Go back and check it again if you can't remember, left or right. But if you start swallowing your food, you can end up doing something called aspiration. And that basically means that because the esophagus isn't doing its job properly, esophagus, proper name for your throat, where you swallow, and it might get blocked up or it might be tensed or constricted, you start sort of chucking food or water in your mouth and it might go down the other pipe, down the windpipe into your lungs. Okay. And if that happens and you start filling up the lungs with food, you could lead to chest infections such as pneumonia. And also the food or the water in there can irritate the lungs and causing them to spasm, which is quite painful as well. This is known as aspiration. When you've inhaled something, you shouldn't. And we know that we often have a gag reflex in trying to cough them up. So at the very least, someone might cough and splutter. But at the very worst, if their gag reflex isn't working very well, it might stay there and cause them a lot of grief. So swallow test really should be done by a speech and language therapist. So if you're working in a care home and somebody's recently had a stroke and there isn't a clear swallow test, you should check and ask, go through the notes and say, has a speech and language therapist done this? And, if you're really unsure and if someone's sort of quite disabled by their stroke, bedridden and really not moving around very well, make sure to be on the safe side to get the speech and language therapist in to do your swallow test. The last thing you want to do when you're caring for someone is to choke them or put them in a situation where you create a chest infection. Test is quite simple. They just give a person a few teaspoons of water And if this sort of goes down without any choking or coughing, then they do it with a larger glass, and then they assess the reaction really. And if they are still unsure, they might give them something a bit more to drink, so they test it out gradually. Then they'll leave a report saying that they've done all the tests and someone's actually swallowing okay. If they have any difficulty swallowing, the speech and language therapist will do a more detailed assessment, and then maybe some sort of give you some guidelines and intervention in what to do. They don't normally allow people to eat or drink until they've seen the therapist. So hopefully, if you've had someone in hospital with a stroke in casualty A&E, they should do that there, so that when they come home to you, if you're in the care home, you should have your swallowing assessment. If for some reason it hasn't happened, as I said, you do need to contact the hospital again and say, look, what's happening? I might just not have sent the report along. But they really should do it before they discharge the person. So it's something for you to know, really. And if at the time they can't swallow, then that doesn't mean to say they'll never swallow. It just means that there's a problem at the time. Sometimes it recovers. Quite often it recovers. And you may have to feed them through a nasogastric tube, where you put sort of a very special liquefied food with loads of vitamins, glucose, energy, and all that sort of thing. And if they're not even really that fit enough to tolerate that, they may at the beginning they might just give intravenous fluids and nutrition for the first couple of days. It's like saline and glucose through a drip in their arm, and then after a couple of days they do the tests, and then they might put them on the nasogastric tube, and then the speech and language therapist will be involved, and every now and then they will check it out until they're happy, and then they'll remove the tube. So none of this is in, as a care worker in a care home, none of this will be your responsibility, but your responsibility will be to learn how to feed someone maybe through the nasogastric tube, how to change the bags, how to sort of put together the stuff that goes in it and mix it up and that. But you should have proper guidance, and it would all be written down for you. Few other tests that are done: heart and blood vessels. They might look at later on, once they've intervened, they might want to confirm exactly what caused it. So there are some more specific tests looking at the heart and blood vessels. One of them is a carotid ultrasound. Carotid is a huge artery that runs down alongside your jugular vein. Okay, so you've got a massive vein and a massive artery, both of them carrying huge amounts of blood. The carotid artery is carrying blood back up to the brain. The jugular vein is venous, so it's carrying blood down to the heart. Okay. So an ultrasound scan can help to show if there's any blockages or narrowing in the arteries that lead to the brain. So sometimes the blockage isn't in the brain itself. It could be in the big arteries that feed the blood into the brain. Okay, so or around, usually here around the neck. And they would do a little ultrasound, as you can see by my graphic. The person's got a little standalone ultrasound, and they can show when there's a blockage, because of they should see the waves of flowing blood. If you have a look at the picture below, there's there's a little waveform, and that's the actual pressure of the blood. There'll be an interruption in that if there's a blockage, and they bounce back. They should be able to do that fairly quickly. They can bring a little machine around, and they can just wheel it around to the bedside and do it. So the nurses are usually quite capable of doing that, and they will try and do that. If they can't really find through a CAT scan something up in the brain, the next thing they'll do is the carotid ultrasound, seeing if it's coming from one of the big arteries, and they need to do that fairly quickly as well. Another thing they'll do is an echocardiogram or an ECG. We've all heard about those. They put electrodes on your chest in a sort of semicircle, and they look at the sort of rhythms really of the heart, I suppose. So they'll use an ultrasound or they'll use electrodes, depending on whether you're doing an ECG or a TOE. Okay. Sometimes they'll even put an ultrasound probe down your throat and then have a look and see if there's any blood clots further down. So we're looking at blood clots further down here. So where a blood clot is maybe thrown off from the heart, it hasn't quite reached the brain yet. Okay. And that's quite possible too. So this is more detailed looking. Or they might check if someone is prone to blood clots, they may check the brain, they may find one in the brain. But if they think someone's having breathing problems, they might check the heart as well, just in case there are more clots down there. Or if they find that if they find that the blood's getting sticky and thick, they may do routine check elsewhere just to make sure there aren't any other clots around. So lots of reasons will push them into doing that, really. So as we know, just running over the process, just so you can think about it, what do you do immediately? It is a medical emergency. You need the tests actually start in the ambulance. So the ambulance, the paramedics will be starting to do some of the major tests before they get to hospital. They will have done their fast work. They'll be looking at blood pressure so that when they get in there, they can tell people what they think. They will do a medical history, maybe from you if the person that you're looking after is, not really conscious. They'll do a general physical exam with, as I said, all the blood pressures. That the paramedics would have done that, mental alertness, checking how you're speaking, seeing, or how you might have walked. Could you walk? Could you not? Then they'll do the neurological exam, finding out if your cognitive abilities have been affected. Again, if someone's not very conscious, obviously they won't be able to do those. They'll do them later on. But it just helps with the diagnosis. So it is an immediate process. That's the most important thing. And all of the really important stuff happens within the first 48 hours, really. Remember this because there will be a question about it, asking you about that. What do you do in those acute period? And the acute period in this case usually means the first 2 or 3 days. Okay. So when we get to that question in the assignment, I'll just remind you of that. Once you get to hospital, all the rest, any examination that hasn't been dealt with will be dealt with there, and the diagnostic tests such as CT and MRI will happen, and maybe some medication to break up clots they might bring that in very quickly before they do anything else. Okay, so that's it really. That's it about the investigations for stroke. What I'd like you to do before you move on to the next set of PowerPoints is have a look in your extra reading. There is a document comparing MRI or CT, building a little bit on some of the things that I've already told you, comparing the two types of scan. So I'd like you to have a read of that, make your own comparison, and maybe try to come up with a conclusion for yourself about what you think might be best in the case of stroke, because that's what that's a question you'll have to answer for your assignment. So you might as well start reading about it now and thinking about it. Okay, that's it for this session. Thank you and goodbye, and I'll see you again.